met when I was doing my postdoc in New York City in 2008, and I worked on the fascinating research of staying safe, how long-term injection drug users stay safe in the long run, and since when we collaborating, and now there's a very troublesome but interesting development in New York City, which concern a new wave of opioid use, starting with prescription pills and sometimes it spills to injection drug use. And Pedro got a big project on that and got a lot of fascinating questions and maybe some answers already, which he's willing to share with you. So Pedro, the floor is yours from NDRI, National Development and Research Institution in New York City. Thanks.
Okay, I want to say it's a pleasure to be here. Ever since I was a kid, I have been fascinated with Russia. So this is my first ever Russian trip, and it's very, very pleasant that it's St. Petersburg because it's clearly a gorgeous city. So it's an honor to be here, and I appreciate to have a dual audience of Moscow and St. Petersburg. This story is interesting on multiple layers. In terms of a bit of a historical background in New York City of heroin use, historically, heroin use in New York City has been concentrated in the inner city metropolitan areas among young urban inner city youth, African American and Latinos. Now, something very important and drastically different happened early in the 2000s. There was a huge increase of access to prescription opioids. Prescription opioids are this medication that traditionally have been used for cancer treatment or for very severe pain treatment. However, there was a movement in the United States initiated by doctors and pharmaceutical companies to pay wider attention to pain and consider it a critical vital sign, and if patient determined that there is a problem with pain, be very aggressive in treating it and providing prescription opioids. Now, very interestingly, from the 2000 to 2010, 2012, the amount of prescription opioids prescribed in the United States has been humongous, has increased drastically. And you might think, what is the relationship between prescription opioids, which is a medication, it's a pain medication prescribed by doctors, and heroin use? So this is the same question we had 3 years ago. Now, I don't know how much you heard about this. Now it's less of a question. But when we put this proposal together, now we are in the third year of the grant, there were very clear empirical questions whether or not these young people that start engaging in prescription opioid use, they might or might not to transition to heroin. So why is that important? For multiple reasons. I'm going to give you some examples here in terms of background. Okay. Oh, no. Wrong thing. 1 second. I think I got it. Oh, yeah. Yeah, okay. So this is a bit of the background. I should have more detail, but while the recent nationwide epidemic of opioid use has been very well documented, there's relatively little research on the implications for HIV. Clearly, this is a huge summary of what happened. So let me give you a bit of a wider background. Up to, now I have to speak of memory. I think up to 10% of adults in the US have used non-medical prescription in the last year. And I have this number somewhere else. This number is higher among young people. Up to 15% of young adults in the United States have used prescription opioids non-medically, meaning as recreation or without a prescription. So clearly this created a huge pool of young people in the United States that are becoming opioid dependent. And you might say, well, does everybody become opioid dependent? Well, clearly no. But if you have such humongous pool of people who are playing around, if you will, with prescription opioids, it could happen that a relative small number of those might become opioid dependent. So when the number is so high, as 10-15% of the adults, the risk of this transition becomes much bigger. Now, why is that different from previous heroin use in the United States? Because this is happening nationwide, in rural and in suburban areas. So what has been and become evident in the last 3 or 4 years is that we see a movement of heroin use in areas where we didn't see it before. For example, Vermont. Vermont is a very clear example. 2 or 3 years ago, the governor of Vermont dedicated the State of the Union address exclusively to how to deal with the problem of prescription opioids and transition to heroin. With an additional problem that also has become a huge problem in the United States, which is overdose deaths. And why is that important? Clearly because a lot of young people are dying, and they are dying of overdose. Now, this problem has become such a critical problem in public health that currently more people die of overdose, drug overdose, than car accidents in the United States. So it clearly has become a huge problem that needs to be tackled. Now, as Peter has mentioned, we have done a good 15 years of history doing HIV research among heroin users. And our big empirical question was, what was going to be the implication of this prescription opioid use towards drug injection or not, or whether or not there was going to be a transition to heroin. All right, so this is what we decided to do. In New York City, and this is kind of interesting for your lab, and I will be very curious whether or not you have used this methodology. What we decided to do is we decided to do what's called a respondent-driven sample, which is basically a coupon system where you, a user, recruits another user who recruits another user. It was developed by Thorne at Cornell University, and it has a website dedicated to explain the methodology and to provide software for analysis. What is very, very interesting about RDS, respondent-driven sample, are a few things. Number one, it's very, very effective in recruiting hard-to-reach populations. But you might say, well, we were doing a snow sampling before. Why is this different? The big difference is that Thorne and his lab in Cornell developed a methodology where you can make population inferences based on this sample. And that is a huge leap forward, where in a methodology that you do a snow sampling via a coupon system, once you do the analysis, you have the sample results, but also if you have enough and controlling for certain aspects of the sample, you could make population estimates. And we were very, very interested on this because we wanted to know multiple things. One, how many prescription opioid users, what percentage rather, were potentially transitioning to heroin, and how many prescription opioid users were transitioning to drug injection. Now, I'm going to talk a little bit more about RDS for this audience. Yeah, is this useful? Mm-hmm. All right. So RDS is a relatively simple method in that, say I'm a drug user, yes? And say in our study I'm a prescription opioid user. So our eligibility criteria is you have to be 18 to 29. So we were only interested in the young generation because we were very intrigued whether or not this new young generation were potentially transition to heroin or not. So we focus on 18 to 29, right? And also very critical for us, we wanted them to be prescription opioid users. No medical use of prescription opioids. So this is non-medical users of opioids. Non-medical user of prescription opioids. That means we were not interested in young people who went to the doctor and received a prescription and they were using as prescribed. We were people interested in young people who use prescription opioids recreationally. Right. So we had what's called seeds. Seeds are this group of people that you start the study with. In qualitative research, oftentimes it's a key informant or somebody you know to be a player, right? Now, you interview this person. We have a questionnaire of around 900 questions. 900. It takes around an hour. Because we have multiple layers of areas of interest. It sounds like a lot, but really within an hour there are certain follow-up questions that are not part of if the person doesn't qualify. We also put a lot of thought in the questionnaire because we have 15 years of history. So I knew certain areas that I wanted to ask. For example, one that's very innovative is adverse childhood events, childhood trauma. We also were very interested on networks. Sam and I, Peter and I have a common mentor, Sam Freeman, who has done great work on social networks. So we wanted to pay careful attention to injection networks. We also wanted to pay very careful attention to sexual behavior. Other concepts that we developed, such as intervention, which is assistance or protection among drug users, we were also very interested. Anyway, we have like a good 12 sections. And if you're interested, I could send you the published papers so you could see. Anyway, so the seed is interviewed. We do HIV and hepatitis C testing. So via blood, antibody testing. We do the interview, which is about an hour to an hour and 15 minutes. And then we pay the person for coming. We pay, I think, around $40. Then we say, do you know anybody who uses prescription opioids and is 18 to 29? And if the person says yes, we'll say, if you bring somebody, you refer somebody with this coupon for the project, we'll give you an additional $20. So the person is vested in referring 3 more people. So we get these 3 more people. And then we do the same. Testing, interview, and then they refer. And then we do these interviews in the field side, and then they refer. So you can see methodologically how out of one seed I could easily get, I don't know, just like a lot of little bolts. But you could see it like, and I have some networks that I will show you, the real networks. So this is called respondent-driven sample. And again, the beauty of this methodology is, in a way, you get the best of both worlds. You are able to target sample hard-to-reach populations, yet you can also make population inferences that have huge implications for policy.
If the chain is long enough, right?
Yes.
But if it's short, it is fine.
Right, but we're working with a group in Massachusetts with Krista Guile, who is the RDS expert, and we actually, her work is very interesting because she can detect the actual bias driven by each one of the seeds. and I don't have it here, but supposedly, say each seed, each network brings a different bias, but if you, like you're saying, it reached enough and that you might find a point of equilibrium. And that's where the population estimate will come. So as the N increases, there's certain tendencies that become population estimates, that they are being, the bias originated by each seed kind of gets diffused as the N expands.
I wonder if you weeded out the short chains, or if you had short chains in your...
We did, I'll show.
And you weeded them out or kept
No,
them?
no, you keep them. You keep them. You keep them because the N, I'm not, you're probably much better expert. You factor that in, but you have, ultimately, if the seeds are long enough, and there's one that's homophily, differences within the referrals, you can make a population estimate factoring in those limitations. So our data analyst could speak in more detail about those details. Now, so I spoke of the recruitment, an RDX, a chain referral, eligibility criteria, opioid use, either non-medical and heroin use. In the past month, so we wanted users who are kind of regular users, verified by urine, that we get a urine test to make sure that they have certain drugs and opioids, either heroin or the prescription opioids in their blood system. And self-report, visual examination if they are drug users. 18 to 29, we do check for IDs. For us, it was very important to keep in this population because we knew quite a bit about the older population, and our sense, and you will see in the sample that it was confirmed that this was a very different population of the traditional population of drug users in New York. And these are some of the areas that we ask about: overdose, drug use practices. Yeah.
Just 15 minutes of your time left. 15.
Oh, okay. So I gotta move fast.
Yeah. I'm just keeping you.
Yeah, good. Thank you, Peter. So let me go to the. All right. So this is the sample. Let me put the timer actually. So I don't want to run out of time. All right. So this is the population, and here you start seeing interesting characteristics. Mean age 25. Standard deviation 3. 30% female. So this is a really very different from other studies of drug injectors in New York, where the mean age is around 35. Like Don Desjardins, a very famous and well-known researcher who also I consider my mentor, he has a study that has been going on for at least 20 or 30 years called Risk Factors, and the mean age of his population is around 35. So this is a very young people, very female 30% is higher than other studies. Look, very, very important here. They are white, mostly white, which is very different, say, of the study that Peter mentioned in the spring trade, where we had a very small population of white. Also look at the education level. So higher educational, most have high school diploma, or up to 41% have college experience or currently enrolled in college. And then also notice the income.
It's rich. They're rich.
They are, well, in New York City this is not rich, but certainly in the study that Peter and I did in the past with other drug users, this was our population. So this is clearly white, middle class, and it's drastically different from other studies among drug users.
Just check.
Yes, please.
Those responses during the sample, or is it because they're younger users which are, more white than the others?
I think it's because, and the population estimates lead in that direction, is because this new population of prescription opioid users initiated their experience with opioids with pills, with prescriptions, And currently in New York, that is more of a white middle class experience. African Americans do not touch these pills at the moment. Latinos we're finding some groups, but clearly they are overwhelmingly white. Now, this starts very interesting. Mean age of initiation, 16. So they started playing around with pills when they were in high school. They all have used prescription opioids, non-medically. And this is where our studies start telling a very interesting story. So they started prescription opioids at 16, and they transitioned to heroin at 19. And look at this. It took about 3 years to transition to heroin, but the moment they hit heroin, in less than a year, they started injecting. And that speaks to what we know about heroin use in New York, and I don't know how it's here, but this population stays very, very little time sniffing heroin. There's a very fast transition to injection. This is also very important in that it's telling us that we need to reach these young people before they are 20. Because by the time they are 20, they have transitioned to heroin and they have transitioned to heroin injection. Additionally, it's of great concern because they have not been on drug treatment yet. So clearly we have to reshape, we have to change our way to reach young people so we prevent their escalation to opioid dependency, and if we catch them at the moment of injection, we teach them about safe injection practice, especially related to hepatitis C risk. So this is a bit the trajectory. I don't know why I have these question marks. Why is this like that? Maybe we can look at here. So, it's the same. Okay, so basically what we did here is present each one of the ends for each one of these variables. And then we determine a two-tailed test to determine if these differences were in fact significant. And what this does is give us a clear trajectory. It basically confirms the trajectory that I was speaking of before. This graph will be here. This graph, I think, is a summary of the previous graph, and this is really the truest story of concern that is happening in New York, and we see it happening elsewhere in the United States. The PO initiation is at 16, the heroin is around 19, and at 20, you have heroin injection. Now, why is this important? Because potentially you have a new cohort of drug users in New York City who might or might not be reached by harm reduction services, who might or might not be reached by drug treatment or opioid substitution therapy, who clearly are in need of addressing their opioid dependency. We wrote a paper on qualitative research that the young people were telling us that were transitioning to heroin as a way to cope with their dependency. So they saw heroin as a solution in that they're similar to other studies, the cost of the prescription opioid was so high. Just to give you an example, a pill of oxycontin in New York City in the street market can be $50. Just one pill of 50 milligrams. A heroin bag in New York is $10. It has been $10 for as long as I've been doing this work. At least 15 years.
15 years.
Yeah.
So about the same time when the U.S. invaded Afghanistan, in other words.
Okay, sorry. Yeah. So the price has not changed very much. All right. So now here. Remember I was telling you our critical part of our study is injection risk, because in our field, I'm not sure you guys don't do a lot of immunological work. In our field, the most critical aspect or pathway through HIV hepatitis C drug injectors is injection risk. Now, these are very young people, but look at their injection risk behaviors. They are very high. So, 79% of the sample report injecting drugs in the last 12 months. Of those who report injecting drugs, 48% did not share syringes. Distributive syringes means I'm injecting and I give it to you so you can inject. So that's distributive, right? So half did not, but the other half did. And look, 23% gave people to you, and to you. So I share my needle with at least 3 individuals. So those are high percentages. If I were to be positive, it's very likely that the 3 colleagues here will become positive. So to follow the needle is very important in our work and understand the epidemiology attached to the needle and the virus, the distribution of the virus among injection networks. Now, this is also very, very important. How many people did I receive syringes from? So 57% say did not receive, about half the sample. But look at the numbers. 75 received from at least 1 or 2 people, and 8% received from 3 or more people. Now, this is for syringes. We think this is relatively lower because the young people knew about syringes, but they did not know. They were not aware of the risk of sharing cookers. So you can see.
Cooker is a spoon or what?
Yes, the spoon. Yeah. Cooker is, so in New York, how you cook drugs. It's very important to know. But that's the first thing I teach my students. This is how you buy drugs. You buy the bag of dope, that's $10. You put the drug here. You put a little water to remove it. And then you get the syringe here. Yes. And you put the cotton, and you put the syringe. Now, it's important to know that if I get my syringe, and Peter has his syringe, even though we don't sell syringes, if we share the cooker, we still could transmit hepatitis C. Because if I use this needle twice, and I'm positive, and I go first, Peter can get it via the cooker. Because hepatitis C is very easy to transmit, much easier than HIV, via the cooker. Now, you can see that these are very, very high risk factors. In an environment like New York that has very good 20 years of solid harm reduction services. So we are very concerned about this number. And you might say, well, Pedro, don't worry, these are young people, they come from middle class backgrounds, there is no HIV and hepatitis C in this group, so no matter if they share, they won't get infected. Well, unfortunately, these are the results. Very, very troublesome results. We find that 31% of the injectors tested were positive for hepatitis C. 31%. 1 in every 3. That's very, very high for such young people who, should they not be injectors, their prevalence of Hep C will be 0. So this, we think and we know that this is directly product of their injection risk behavior. Now, the relatively good news is that only, quote-unquote, 1% are HIV positive. However, with the previous risk behaviors, that could change. And you might say, oh, it won't change. In Indiana, I don't know if you heard about the Indiana case. In Indiana, there was a case of a fastest spreading HIV epidemic among prescription opioid users. And it's a clear indication that HIV can move very, very fast in these networks. This happened recently. All right, so now this is something that you might want to see. We broke down the hepatitis C established by years of injection, and this is something that we kind of knew. Basically, how fast the prevalence increases within the first 3 years. So you go from 0 to around 21% prevalence within the first 1 to 4 years. Now, you might also, this is another way to present this, and this is where Edward was asking me about the network. This is the actual network. So each one of these are the seeds, and these are the different chains. The red spots are the hepatitis C positive individuals. So, and then this is broken by borough, which is something that a lot of researchers have not done, and we will do. In fact, Peter might be interested on this. We are now writing a paper on the different prevalences within the different boroughs. So we don't treat New York as a unit of analysis. We treat each one of the boroughs, each one of the major parts of New York City as so you can see Manhattan and Staten Island, male and female. What do you see here in terms of hepatitis C? One thing that's clear, we thought that maybe hepatitis C was going to be concentrated in 1 or 2 networks, the riskier networks, say the homeless users, or those in Manhattan. It turns out that unfortunately, hepatitis C is pretty much spread all throughout the different networks. And that's worrisome, because in epidemiology, say all of us are drug injectors, okay? And say none of us are HIV or hepatitis C positive. We can share needles and we will not get infected. But I go outside and inject it with my friend, and we continue sharing needles. I'm positive. Maybe in 6 months, 30% of this room will be positive. And this is what worrisome. It's worrisome that this is so embedded in each one of the different networks, which is telling us, in terms of prevention in New York City, we have to focus in these networks that are so young, because the prevalence can get very high very fast. Just to give you an example, in St. Petersburg, I think the hepatitis C prevalence among drug injectors in St. Petersburg, I think is around 90%.
95, 97.
97% of hepatitis C, and HIV is around 60%?
Yeah.
60%. So you could see how potentially this could be a huge problem. Now, this is a bit of a conclusion. Clearly, and this was an empirical question, and it's not always that we ask questions we don't know the answers to. So this is really an empirical result of our work. Early initiation of opioid use leads to opioid dependency, heroin, and drug injection. Non-injection drug use of opioids and heroin precedes drug injection among our participants. Many non-medical users of opioids transition to heroin and drug injection. Young opioid injectors are at serious risk of HIV, of hepatitis C infection and HIV potentially. HIV prevalence is low but might spread, like it's spread in Indiana. Harm reduction services should make efforts to reach these prescription opioid misusers who may be unaware of some of the hepatitis C transmission mechanisms. And this is our ultimate recommendation. Prevention efforts should prevent escalation of opioid use. We think it's important to provide medical assistance to these young users previous to their transition to heroin, be it buprenorphine or methadone, so they can go to the doctor and say, "Doctor, I have a problem. I'm taking too many pills," rather than go to their friend and say, "Hey, John, I have a problem. How I'm going to deal with the pills?" And the friend says, "Well, maybe heroin is the best way to do it." We think, and this is critical, to increase awareness about safe injection processes and HIV risk associated with sterile syringes among this group. And that's it. believe this year probably.
So why is it so cheap in New York?
Wow, heroin? That's a good question. There's different theories. I think New York is a hub of heroin distribution. There's multiple countries that are producing heroin. During that,
More than 90%, I think it's Afghanistan.
well, that used to be the case. However, during the Afghan war, there was a huge disruption of the heroin market coming from Afghanistan, and some Latin American countries became producers of heroin.
What, Colombia?
Colombia. Colombia became a huge producer. In fact, I do a study in Colombia because I'm very interested how local production creates local demand. And we have a very similar study in Colombia about young users, and unfortunately the production led to very young users starting heroin use without knowing anything about HIV prevention or without having a widespread access to syringes. So we have, interestingly enough, similar prevalences of hepatitis C. So in short, it's very lucrative.
Wholesale prices.
You can, wholesale prices, you can make a lot of money. It's a hub for the rest of the United States, and there's competition.
And I have a question, just a clarification question maybe.
Peter, there's a question.
Yeah, sorry. I have a clarification question about this prescription opioids. So just tell how a person can buy it. So he or she just walks in to the pharmacy store.
That's a good question.
And just without any prescription from a doctor.
Okay, that's actually an empirical question. There is this perception that a lot of people that started prescription opioids from the medicine cabinets of their homes, because mom or dad had it available. However, we think it's all of the above, meaning there's street market, there's people who get it prescribed and sell it, there's people who get it from friends or relatives and sell it, and it's clearly similar to the heroin market, and now there is a street market for prescription opioids. But in my qualitative interviews, what was very, very clear in some of the high schools, that the kids were taking it recreationally, as part of their party scene. So they will smoke a joint or marijuana, they'll go to the movies and they'll peel a pill, or they will have a pill party. So it's really part of the drug recreational use.
It's also probably, I don't know whether it's valid now, there's so-called pill mills, where there's doctors basically prescribing everyone for a small fee.
Yes.
So other pill mills there now.
Florida was a very well-known pill mill. Now, although this is changing drastically, Peter is right that this was very widespread. But since now this has become a drug policy issue, and there's a lot of attention because of the overdose and because of the access. Now there is more. There is, in fact, criminal justice attempts to identify those doctors and in fact arrest some of them. So there is more, doctors are more cautious about those practices. But certainly there was an overflow of pill access. Now the dependency has been created, and our concern is not that if you constrain the market too much, you might be pushing people towards heroin, which is a huge problem. That's why we recommend to really address the restriction of pills, while at the same time you do a widespread effort in expanding access to buprenorphine or methadone as a way to cope with, to help young people who are dependent to have pathways to deal with their dependency and avoid the transition to heroin. Yeah.
I got a question. Sir, I think that, thank you, it's a very interesting presentation, of course. In terms of recommendation of opioid substitution treatment, methadone and buprenorphine, it seems to me a little bit, being liberal as I am and been working with the field so long, a little bit maybe more prematurely to divert people to, in most cases, lifelong dependence on buprenorphine or methadone instead of trying some abstinence-based treatment, Narcotic Anonymous and other stuff methadone programs are okay, but shouldn't we just try to get people on drugs first?
Well, that's $1 million question to anybody who deals with it. Now, the mean age is 25. So after they transition to heroin and they transition to drug use, their mean access to different multiple drug treatments is 7. So they go to multiple drug treatments. A lot of them are withdrawal, abstinence-based, and there's relapse. Now, you say we condemn the people to lifelong dependency on methadone and buprenorphine, which might or might not be the case, but what is it better? Lifelong dependency on heroin and being HIV and hepatitis C positive, or medically assisted management of opioid dependency that eventually might end up in abstinence. So I don't think that's really a dichotomy. I think clearly the dependency is so severe that people are willing to transition to heroin. Methadone and buprenorphine doesn't seem so bad. Of course, if somebody is not even dependent or somebody only takes pills recreationally.
And you divert them to meth.
Oh yeah, no.
And it's very, I mean, it happens that people get off meth, but it's, as an expert, it doesn't happen very often.
I think it's a matter of the options that person has, right? So if the person is about to transition to heroin, and the person doesn't know about the buprenorphine, I think it's very, very viable and advisable to manage the opioid dependency with buprenorphine rather than transition to heroin. Now, it might be a fallacy to think that if those with high dependence, they go to abstinence-based programs, that they can actually not relapse. It is often the case they do relapse.
But shouldn't we try first abstinence-based?
Well, this population is trying and is failing at it, unfortunately. I would love for the abstinence-based programs to work, but I think the evidence is that for severe opioid dependency, methadone and buprenorphine works.
Okay. Are there any questions from Moscow?
Yes, we have some.
I can come there. Thank you very much for this presentation, because this problem is all over the world, and in Russia we are sure that also. So the question is, have you found any correlation between the household income or during growing up, or probably between the education and the amount of drugs they just put inside, So probably there is any correlation between these or not.
If there is any correlation with household income and the amount of drugs they intake?
Yeah, and between the education, or probably you were working with the age while the person who was in work just tried to work with drugs or not, probably.
Well, the interesting thing about this population is that a majority have higher education experience and high income. There seems to be a slight delaying effect. People with higher incomes might, and still we have to explore this, might take longer to transition to heroin, because we suspect they might have a longer buffer to be able to pay the high price of prescription opioids for longer periods of time. But we are not sure about that.
Okay.
I'm not sure you're answering her question.
Yeah, you're answering, but I was just thinking about the income and if they were
Yes.
in correlation or not. So I was
Income
working.
and-
Yeah, thank
There is
you.
a relationship between income and drug use. But this is, I think, what you said, is that, you know, these are people from rich, relatively rich families.
Yeah. So, in fact, not only family, but also neighborhoods. For example, where in the rural that this is the highest problem in New York City is Staten Island, which is one of the areas where you have a higher percentage of white middle class population. So clearly, and why we think this is a middle class problem is because they have access to health insurance, and they might be more prone to have ability to have prescription, and they might be more of a surplus, if you will, of prescription opioids that have been used medically that might be diverted to non-medical use. Clearly, in New York, this is a middle class problem. Historically, when we were doing other studies of drug injectors, were concentrated in the inner city and among African American and Latinos. Now it's different. This is a drastically different group.
Okay, thank you.
I have a question about your sampling. I'm sorry, maybe I need something. But you collected about 260 questionnaires, and how do you understand that it's time to stop collecting data?
That's a great question. This is how I understand it happened. Our goal, final end, is going to be 600. So currently we are still recruiting data. We're recruiting participants as we speak. We have a great team in New York, and we're still expanding the recruitment chains. We don't get new seats, but the chains are expanding. Now we think 600 ought to be enough. In older RDS studies, between 300 and 400, the studies reach population estimates are reliable. Again, it's based on homophily and about the characteristics and about reaching a certain point of equilibrium. That the statistical program developed by Ecothorn indicates that it's a little bit equivalent to saturation in qualitative research. It reaches a moment where all the differences, say for hepatitis C, is reaching around 30%. And all the new data doesn't change that level of prevalence. But again, I cannot explain this in very deep technical terms because I'm not a data analyst. But the data itself, the end, it gives you the point of equilibrium.
And what are the rejection rates?
The rejection, people who don't want to be
Yeah,
on the study? Okay. Most people, in fact, they wouldn't come to the storefront because it's a coupon and I give it to Peter. So if Peter doesn't come to the storefront, well, however, the other aspect of rejection is Peter pretending to be a drug user and he's not.
I want the money.
He wants only the money. So I think we have rejected probably around 12, 15 people who were claiming to be, and we detect them not being, either by the urine test. We have a visual test. They have to identify pills. If they say they are in drug injectors, we want to see their track marks. So we have had some cases like that, yes.
Well, not too many, yes?
Not too many. We have a very, that's the problem at times. We have a very severe test to determine eligibility. Because for us, this study is very important, and we don't want people to claim to be prescription opioid users and not be, because it really would dilute the importance of the study. So, and our incentives are relatively high, so we could see why people would want to be in our study.
Yes, okay. Anybody else from Moscow or St. Petersburg for that matter? Okay then, let's say thank you, Pedro, once again.
Thank you very much, Moscow.